Hi, Michael. How are you?
Hi, Jaime. How are you doing this evening?
Good. It's good to see you.
Good to
Last
see
week
you too.
I didn't have a beard and you had a beard. Beard, not beard. I mean beard, not
Yeah.
beard. Now you shave, and then I left my so
So you have to tell me. You have to tell me when you are going to shave, so I can grow mine back.
yeah. How's everything in New York City?
It's getting worse, unfortunately. The cases are going up. Schools, we don't know if they're going to open or they're going to be closed. Houses of worships, we don't know if you're allowed to go to church or to temple, and it's a new abnormal.
Yeah, well, it's and it was the peak of the epidemic at the beginning. Then you were able to really lock it down, and then we people don't understand that we have to watch out for this uh, strange way of living. The new abnormal is a very strange way of life, don't you think?
Yeah. But I mean, we are very happy that the vaccines are coming, but obviously there is a
Yeah.
problem with the vaccines as well. I'm going to talk a little bit more about it later on in the program.
Yeah. Well, I was making numbers the other day, and there are 120 million people in Mexico. If you do 20,000 per day, 20,000 people, because you need to keep the vaccine in a very special place, like 70 minus 70 degrees Celsius and all this. Well, you're going to talk about it, but if you do 20, it's going to take 6 years to vaccinate the whole population of Mexico, and that's only one dose per person, because apparently some are two. But well, anyway, we are completely live. Thank you for being with us. This is our 20th program, Michael. Well, 10. We've done 10 together. This is the 10th program together on this format of Genie in a Bottle. I've done 10 in Spanish, and we've done 10 in English together, counting this one. It's 16 degrees in Mexico City. We are completely live this first day of the last month of the year, 1st of December. It's 2006 in Mexico City, 2106 in New York. And we have a very, very special program for you guys today. Don't you think? We have
I
a
think
very good lecturer.
it's a good program. I don't know about the lecture. We have to see.
No, no, no. I'm gonna stamp on the on the lecture tonight. But as you know, Michael and me we have been doing these programs in a pro bono way. We don't get any honorarium whatsoever. Neither do any of the people that have appeared in this program. We do have sponsors, and we thank them very much. It's Ideas Dentales, Fast and Sharp, and Colgate Palmolive Mexico. But it's just to keep up with this very beautiful production. And now when we talk production, I want to thank Maria, Blanca, Erin, Miriam, and Santos, who are doing one part in Mexico City, and all the people from Grupo Produce in León, Guanajuato. I had a lot of fun with you guys uh, last week. Well, 10 days ago, when we did the dental sphere. I think it was a nice experience. It was a little stress at the time, getting in and keeping the flow like nothing. Like the show must go on, nothing happens. But anyway, I think it came out great. People were very satisfied with the results, with the content, especially. I think it was a very good selection, very good content. But let's use the time to hear you. So I think we're gonna go to a video, and then when we come back, I'm gonna reintroduce you to our audience tonight as the VIP speaker of tonight. So just don't go away. We'll be right back.
Observa el estado de la salud de la cavidad bucal mediante la detección de actividad bacteriana de una forma más clara, sin la necesidad de utilizar agentes externos. Visualiza placa dentobacteriana activa y no activa, microfracturas, filtración de restauraciones, caries, desmineralización, valoración de estado periodontal, valoración de prótesis dentales, zonas retentivas de placa dentobacteriana, auxiliar visual para el paciente. Funciona a través de la tecnología QLF, que incide la fluorescencia sobre uno de los elementos residuos de las bacterias. La porfirina que se revelará en el filtro de la pantalla, marcando un color más rojizo, dependiendo de la cantidad de porfirina presente, lo que diferenciará la placa nueva de la placa vieja, así como las zonas de gran actividad bacteriana. Encuentra esta poderosa herramienta para llevar a cabo todas tus mejores ideas dentales.
Well, so now we have this different setup. Michael, it's a pleasure to have you tonight as a guest speaker. And we're going to remind everybody your CV, which is very long. We just selected a few things. You're a dentist, a professor and researcher. You serve as editor of the Journal of the American Dental Association, JADA, till early this year. You serve as president of the American Board of Oral Medicine. You are recovering dean of the State University of New York at Buffalo School of Dental Medicine, where you finish, but you're still a professor there. And then you're editor of 10 textbooks on dental management and oral medicine, and has published over 300 articles on health-related topics. So it's my pleasure to introduce my good friend Michael Glick, and he's going to talk about vaccines, but from the very beginning of the concept. So Michael, the floor is yours.
Thank you very much, and thank you for being brave enough to have me on as a speaker here with you. So if I could have the first slide, please, I would appreciate it. There we go. So what I want to talk about tonight is vaccine and vaccinations, and I also want to put it in a framework of COVID-19, obviously, because that's really what we're really interested in today. Next slide, please. Now, mankind has always been very wary about infectious diseases because it was the number one killer for many, many years until we discovered penicillin and other type of medications. Most people, children, adults, elderly people, they died from infectious diseases. But very early on, 2,000 years ago, it was discovered that some of these very bad diseases, such as smallpox and plague, people who had been infected could actually be protected from getting it again. Here's a quote from one of the old historians from the Greek time, Thucydides. He said, "Yet it was with those who had recovered from the disease that the sick and the dying found most compassion. These knew what it was from experience and had now no fear for themselves, for the same man was never attacked twice, never at least fatally." So technically what he was talking about here, he was talking about immunity. He was talking about someone who got the disease, couldn't get it again. And that was 2,400 years ago. So with that, the keen observers tried to figure out what was it really that helped the man to be able to recover or be protected against these infectious diseases. Next slide, please. Well, it turns out that even the Chinese have known probably for over 2,000 years that if you took pus, or if you took some and grinded up some of the pus or some of the pustules from, for instance, smallpox, either inhaled it in the nostrils or you placed it inside the skin, it could actually be a protective measure for these people not to get smallpox a second time. And to do this was called variolation. So that's what also scratching matters from a smallpox sore into the skin itself, and that was called variolation. And there have been actually illustrations about this at least since the 1600s, but possibly even 200 BC. Next slide, please. It became very popular in Europe around 1700. This lady here, Lady Mary Wortley Montagu, she was actually the wife of the British ambassador in Constantinople in Turkey. And she had contracted smallpox and actually been disfigured from smallpox in 1715. And she found out that you could actually variolate, you could actually put some of the pus from smallpox sores into small sores that you created on someone's arm. And by doing that, you can be protected against getting smallpox a second time. So she did it actually. She did it on her son, who was then 6 years old, and it turns out that he was protected. And then they started to do some studies among prisoners and abandoned children. They got inoculated with smallpox, and eventually it reached all the way up to the royalty in Britain. And from there, it took on that this variolation could be a way actually of protecting people against smallpox. Next slide, please. But we usually talk about Edward Jenner as the father of vaccination. And that was around 1780, 1790. But it turns out that this knowledge of being protected against smallpox by another cousin to smallpox called cowpox was known for a long time. And it's interesting, this was a farmer, his name was Benjamin Jesty. He was a cattle breeder, he was a farmer, and he had contracted cowpox. Cowpox was similar to smallpox, but obviously it affected cows, and it affected milkmaids. And these milkmaids, they were very protected against smallpox, meaning we noticed at the time, that those milkmaids that got cowpox were less susceptible to get smallpox. So Jesty, he figured out that if you have actually got cowpox, maybe that will protect against smallpox. And what he did was he actually inoculated his wife and children during a smallpox epidemic, and all of them survived. And that was in 1789. And actually on his gravestone is written that he was actually the first one to be able to protect his family against smallpox by this variolation. Next slide, please. But he didn't make a big deal out of the whole thing. Next slide. He never published anything about it. The person who published about it was Edward Jenner, and he is now recognized as the father of vaccination. What Jenner did was he took some of the pustules from a milkmaid, her name was Sarah Nelms, and from the sores of her hand that you see here on the slide, he took some of the pus and inoculated it into a young farm boy named James Phipps. So the pus from the lesions from the milkmaid infected with cowpox when inoculated into the farm boy. And what he did afterwards, he actually tried to infect this farm boy with smallpox. I don't know how he got approval to do this type of experiment. Today you probably wouldn't get any approval of doing this, but he did that. And it turns out the boy was protected against smallpox. Now, Jenner wrote this up, and initially people didn't believe him. People didn't think it was such an important discovery, but he kept pushing, and eventually people recognized that this could be a very, very effective way of actually being protected against smallpox. And Edward Jenner, he's the one who started to call it vaccination. The reason it's called vaccination comes from the word vaca, that in Spanish and obviously in Latin comes from cow, came from cowpox, vaxa, it's vaccination. So originally, vaccination was only for protection against smallpox. Now today we say vaccination, immunization, it means the same thing, but traditionally vaccination was only against smallpox. Next slide, please. Another one of the giants when it comes to vaccination was Louis Pasteur, and he discovered several different vaccines. But what he's most famous for is actually a vaccine against rabies. And this is interesting because rabies has a very long incubation period. And what happened was there was a boy, his name was Joseph Meister, who got bitten by a rabies-infected dog. and he was going to die. There was no question about it. They brought the boy to Pasteur, and Pasteur at that time had started to experiment with this rabies vaccine, and they decided they have nothing to lose. They injected this vaccine into the boy, and the boy survived. And this is the first time anyone had actually survived from rabies by this vaccine. And it wasn't really preventing an infection. It was preventing disease from continuing because of long incubation period. Now, interesting story with Joseph Meister. He became very close to Louis Pasteur, and Louis Pasteur had a whole institute named after him called the Louis Pasteur Institute in Paris. And Joseph Meister was actually the person who was in charge of this Louis Pasteur Institute all the way into the 1940s. Next slide, please. Now, going into vaccination of today, there are a couple of terminology that we need to be very clear of. First of all, we talk about control. Control is reducing the prevalence of incidence, meaning reducing the number of people with the disease and the number of people who will get the disease later on. That's controlling the disease. We're also talking about elimination of disease. That means we reduce to zero the incidence of disease in defined geographical areas, meaning in small areas, geographical areas like a state in the United States, we can reduce the incidence of, for instance, neonatal tetanus. So we eliminate the disease in this geographical area. We can also eliminate an infection, and the same thing, the infection, not only the disease, but infection itself, and polio is obviously one example. We can also eradicate a disease, and the first disease that was eradicated was smallpox. Actually, the last natural infection of smallpox occurred in 1977. But it's not extinct, because smallpox still exists in laboratories in the United States, in Russia, and other places as well. And unfortunately, it's being used, or being at least experimented on, to be used for in warfare as some kind of chemical to infect populations. So smallpox still exists, but not in the natural, not outside laboratories. Extinction is when infectious agents disappear completely. No more. It doesn't exist any longer, not in nature, not in laboratories. And as far as we know, there hasn't been any infectious agent that we know of that is completely extinct. Next slide, please. Now, so this is about controlling, elimination, eradicating disease. There are another couple of contexts that we need to understand. One is antibody. Now, an antibody is a protein that is presented on specific cells of a cell called a B lymphocyte. And when someone gets infected with something that stimulates the immune system, these antibodies are being produced and try to attach themselves to this infection, this antigen, this toxin, the foreign substance that comes in here, and protect the body from getting more infected. And this is called an antigen. So a virus is an antigen, a bacteria is an antigen. An antigen could be part of a bacteria or part of a virus. So when the body gets infected or exposed to this antigen, it will produce antibodies through these B lymphocytes. The immune system is very complex. It's a network of cells that defends, and there are actually two different types of immune system. I'm going to talk about that in the next slide. Immunity is protection against an infectious disease, and vaccine is a product that stimulates the person's immune system to protect the person from the disease. So this is the bottom line here with vaccine and vaccination. What we try to achieve with vaccine and vaccination is trick the body. We're trying to tell the body that the body has been infected with an infectious agent, yet it has not. So we're trying to trick it in order to make it produce cells that has memory, and these memory cells will then be there in case we truly get infected with the virus itself. And I'm going to explain that a little bit more into detail. So vaccination is about tricking the body to stimulate the immune system to produce cells that are going to stay there in the background and wait in case we get infected again. And by then stimulating those cells, called memory cells, we will be protected. So next slide, please. So I spoke about two types of immune system. One is what's called the innate immune response. The innate immune response happens in minutes and hours. There are cells involved in that. There are also barriers such as the skin, the gastric acid, the tears, the mucosa. That's the innate immune response. The cells that are involved in the innate immune response, they're not specific, meaning they respond to any antigen, any bacteria, any virus, but they cannot remember it. They have no memory. Now, the acquired immune response is very different. It takes days to develop, and it's antigen specific, meaning it can actually discover that it's been infected by this antigen, that's virus, this bacteria previously, and react accordingly because it has memory cells. So it's the acquired immune response that we try to achieve with vaccination. We are trying to get the body to trick the body to believe that they have been infected in order to create again these memories, the memories of the immune system to react against a new infection. Next slide, please. In the innate immune response, there are specific cells. There are neutrophils, eosinophils, basophils. Those are called the granulocytes. And the neutrophils, they actually engulf the bacteria and destroy the bacteria. Eosinophils, the basophils, goes into protection against allergies and so on and so forth. Then we have monocytes and macrophages. The monocytes, when in the blood, macrophages as soon as they get into tissue. We have mast cells that are histamine. And we have dendritic cells and natural killer cells. Now, dendritic cells and the monocytes are very important. The monocytes and the dendritic cells are also called antigen-presenting cells, meaning they engulf through endocytosis the pathogen, let's say the virus in this case, and then they destroy the virus, but has part of the virus coming up through the cell membrane and present this to other cells in order for those cells to get stimulated. So these are antigen-presenting cells, the monocyte and the dendritic cells. And the cells they present it to are the T lymphocytes and the T lymphocytes specifically. So the dendritic monocyte macrophages, they engulf through phagocytosis or endocytosis bacteria, viruses, and then use this to stimulate the lymphocytes. Natural killer cells are also part of the innate immune response, also not specific for any specific bacteria, but they are part of the lymphocytes, but they're not T or B lymphocytes. They're called natural killer cells. Now, the acquired immune response, they have mainly two cells. There are there's some more, but there are T lymphocytes and B lymphocytes. The T lymphocytes have a lot of different types, but the ones we are concerned about tonight are the helper cells. They're called the T helper cells or CD4 cells. CD stands for cluster differentiation. Each one of these cells has specific clusters on the membranes, and they get numbers. So the T helper cells are CD4 cells. They can divide it into T helper 1 and T helper 2, and I'm going to show you in the next slide or two why. And then we have cytotoxic cells, the CD8 cells. Now the T helper cells, they actually help the B lymphocyte to differentiate into plasma cells, and the plasma cells will then produce antibodies. So the T lymphocytes are helper cells to help to produce the cytotoxic T cells. And the cytotoxic T cells, they will destroy infected cells, and the T helper cells will also stimulate the B lymphocytes that produce plasma cells to produce antibodies. Next slide, please. So this is a virus. The virus, in this case, this is actually a coronavirus, and it has a membrane outside it, and these membranes could look like this. And if you look under a big microscope, an electron microscope, it looks like it's a crown around it, and that's why it's called a corona cell. Now, these things that stick out here, they are spikes, and these spikes are recognized as foreign, and these spikes will then attach itself to receptors on our mucosa, and the specific receptor for the coronavirus are something called ACE receptor or ACE2 receptors. And these ACE2 receptors, we find them in the lungs, we find them in the mouth, and these receptors are the ones that get attacked by the virus, and then the virus enters into the cell. What the virus does is the virus cannot replicate on its own. What the virus does is it contains RNA and DNA, or DNA. In this case, coronavirus is a single-stranded RNA, And what it does, it infects a cell by depositing the RNA inside this infected host cell, and the host cell will then use the RNA of the virus to become a factory to produce more viruses. And that's how viruses propagate. They infect a cell, a host cell, it's now become an infected cell, and they use the mechanism of the cell to actually produce more viruses. Next slide, please. And this is the inside, as you can see, of the coronavirus. This is the RNA, and that's the RNA that get deposited into the host cell, the infected cell. Next slide, please. Schematically, this is the way it looks like. You have the virus on top here, where you see the number 1. It attaches itself to a receptor on the mucosa. The cell on the mucosa will engulf it, endocytosis, phagocytosis. Inside the cell, the virus is going to be broken up. The RNA of the virus is going to be spilled and gets into the nucleus of the cell. Inside the nucleus of the cell, they're going to have messenger RNA. They're going to tell the cell to produce proteins, and these are viral proteins. The viral proteins getting out of the nucleus, and they are actually going to be then put together like a virus, and the virus now is going to get out of the cell, and with the membrane of the cell itself, it's now going to go outside and become a new virus. And that's how the virus propagates. So what we want to do 2 things. We want to, number 1, destroy infected cells, and that's what the CD8 cytotoxic cells do. And we also want to protect the cells from getting infected, and that's what antibodies are for, meaning prevent this virus from attaching itself to this host cell. That's what we do with antibodies. Next slide, please. So this is the coronavirus. Next slide, please. It has a couple of proteins on it. It's called the E or envelope protein. The S, this is spike protein, and the M, which is the membrane protein. Next slide, please. And inside, they also have a nucleus. It has an N protein for the nucleus protein. And the body recognizes, the immune system recognizes all of these proteins and produces antibodies against them. The protective antibodies are the antibodies that are produced against the S protein, the spike protein, because it's the spike protein that recognizes this ACE2 receptor. And if we can block the S protein with antibodies, the virus cannot attach itself to the host cell, spill its RNA, and produce more viruses. Next slide, please. So these are the antibodies. So those are the antibodies that will protect. So here you have the virus. Slow down, slow down, slow down, slow down, slow down. No, too fast. Okay, here we go. So here you have the virus. It's recognized by an antigen-presenting cell, a dendritic cell in this case. You have macrophages up there in the middle, and then you have a T lymphocyte that is undifferentiated on the bottom. Next slide. The macrophages, they're part of what we're going to cause the inflammation, phagocytosis. It's going to start with a fever, an illness, and so on and so forth. It's the innate immune response. Next slide, please. Now, the virus is going to do 2 things. It's going to start to infect the dendritic cell. That's then going to present this part of the virus to the T lymphocytes. It's going to differentiate. It's also directly going to affect the B lymphocyte that you see on the bottom here. The bottom to your right is a B lymphocyte. So the T lymphocytes get stimulated by parts of the virus that has been presented to it by the dendritic cell. B lymphocytes get stimulated directly by virus itself. Next slide, please. Now, there's a lot of interactions going on here. So the antigen-presenting cells will now also stimulate the T lymphocytes to produce the CD4, the helper cells. It will also help to produce CD8 cells. And the CD8 cells, which are the cytotoxic cells, they will now kill infected cells. Next slide, please. The CD4 cells, as I mentioned previously, are divided into TH or T helper 1 and T helper 2. Next slide, please. The T helper 1 will actually stimulate more macrophages and phagocytosis, and would also help to differentiate and clone the CD8 cells to produce more effective CD8 cells, more effective killing cells. And the T helper 2, next slide please, will help to stimulate the B cells to produce the plasma cells, and the plasma cells will now produce antibodies. So this is the acquired immune system. Next slide, please. But what also is going to happen here, what's more is going to happen here is that the CD8 cells are going to create memory cells, and the B cells are also going to create memory cells. So when we talk about an effective immune response from a vaccine, that means the vaccine has actually started this chain reaction. So the body has these memory cells. And these memory cells, both the CD8, the cytotoxic cells, and the memory B cells that produce antibodies are going to be there. So instead of days for them to develop and protect us, and during the time that they get stimulated and so on and so forth in initial infection, that's the time where you get really sick. And it gets too much, then you get too sick. But here we have an immediate response because the person is already primed to have this infection. And this, next slide please. And this is what vaccination is all about. What we want to achieve is create the T lymphocyte and the B lymphocyte to produce cytotoxic cells and antibodies. And this is called the cell-mediated immune response, the cytotoxic cells, and the humoral immune response when we talk about creating antibodies. Now, when you hear about vaccines today, the vaccine development, they talk about, yes, we can measure how many antibodies are being produced. Well, that's okay, but that's only one part of the responses. What you need to ask yourself, or the manufacturer, and we don't have an answer, is how well is the cell-mediated immune response? Do they produce enough T cells in order to kill infected cells? And that's a problem today because we don't have a good measurements how good these new vaccines are to do that. Next slide, please. All right, so how do you create these vaccines? There are 5 different platforms. On the top, we have something called an attenuated weakened vaccine. What happens there is you take a virus, I'm just going to use the virus as an example, and you let the virus go through a lot of different replication until it becomes very, very weak. And then you take this weakened virus and you inject it into someone, and the person is going to start to develop an immune response and memory cells, but not get sick. Now, on the bottom, you see inactivated or killed viruses. There, what we do is we kill the part of the virus that caused infection, but we contain in the virus itself the proteins, the spikes here, that will produce an immune response. So that's an inactivated or killed virus. Then we can take a part of the virus, what they call the subunit, like the spike protein, and we can actually take the spike protein and inject that as a vaccine, and the body is not going to think that's been affected by the entire virus and produce the immune response. And we can use vectors, viral vectors. For instance, adenovirus, which is the normal cold virus. We can inject this vector with DNA of the virus. This vector, this adenovirus, is now going to take the DNA, put it inside a cell, and produce the messenger RNA to produce viral proteins without being affected by the virus itself. But the body is going to produce this type of proteins that's going to generate the immune response. And the latest thing, and the new vaccines coming out, they're called the RNA vaccines or the mRNA vaccine. And I'm going to talk a little bit more about that later on. So today, these conjugated combination type of vaccines, platforms that we have, those are the 5 platforms we have right now. Next slide, please. All right, so we can take a subunit, like the spike protein, and we can also have what's called a conjugated method, meaning we take part of this subunit and we embed it with something that makes the immune system react much more to it. And we can take, for instance, the sugar or the capsid of a bacteria, and we can use that in order to get the subunit to react, to have a better reaction of the immune system. Next slide, please. We can also take the recombinant DNA technology, meaning we can actually take these adenoviruses and we can take the DNA and use the DNA to infect the cell, and then they think that it's actually affected by the whole virus, but it's only producing proteins, so the body will think it's infected by a virus and produce this mechanism to protect itself. Next slide, please. And this is the new things, and this is something you should pay attention to, because you're going to hear much, much more about the second part here, what they call the messenger RNA vaccines. And these are the really new, fantastic vaccines that are being produced today. What they do here is they take the sequence of the virus, and then they figure out what sequence of the RNA produces the spike protein. They synthesize this new messenger RNA, and then they take this new synthesized messenger RNA, encapsulate it in some kind of lipid, like something called a nanoparticle, and then they take this nanoparticle with the messenger RNA and inject it straight into someone's body. Now, the messenger RNA is now going to create proteins because it is a messenger RNA. It's an instruction to the DNA to produce more proteins, and the proteins it's going to produce is going to be the spike proteins. Now, the spike proteins is not the virus itself; it's just part of the virus. But the body thinks it's been affected by the entire virus, and it's going to produce an antibody response and hopefully also a cell-mediated response. So these mRNA vaccines, these are the new ones that are being approved right now. The problem with them is that we have not seen yet any vaccine on the market that is based on this mRNA technology. But they have been tried against Ebola, against Zika virus, and against avian influenza, even against HIV disease, and to some success. Next slide, please. Here's a list of all the vaccines in the United States, and it's a long one. Adenovirus, anthrax, cholera, diphtheria, hepatitis A and B, mumps, meningococcal, measles, Japanese encephalitis. Keep going. Next slide, please. Next slide, please. So you can see there's a long list here. I'm not going to go through all of them. You probably have the same thing in Mexico and South America and Latin America, that you can get vaccines against tetanus and tuberculosis and typhoid fever and varicella zoster and yellow fever and so on and so forth. Keep going. What's important to know here, though, and I'm not going to go into details about, that some of these vaccines are built on attenuated viruses. So obviously, if you're immunocompromised or someone is immunocompromised, if you give them a weakened virus, they can actually get sick by that virus. So there are actually indications or contraindication what type of virus you can get based on your age and based on your immune system. Next slide, please. Now, this is a tremendous resource if you want to get into and know more about vaccination. It's the Advisory Committee on Immunization Practices, or ACIP, Vaccination Recommendation and Guidelines. You can download here a 148-page monograph about every vaccine available in the United States, how they work, how they're manufactured, who should get them, who shouldn't get them, etc., etc., etc. Now, next slide, please. What I just want to make you pay attention to here are three things. When you give the vaccine to someone, the type of vaccine is based on the age of the recipient and the immune status of the recipient. Now, the reason I'm saying this is that in the United States, we talk about maybe dentists started getting involved in providing vaccination to their patients, not only advocating for them to get it, but actually performing the vaccination itself. In Oregon, as an example, dentists are already allowed to give flu vaccination. But you have to be very trained. You have to be trained in who should get it, when you should give it, and who shouldn't get it. Next slide, please. Tetanus, diphtheria toxins require booster doses to maintain protective antibodies. Unconjugated polysaccharide vaccines do not induce T-cell memory cells. Conjugated with protein, they improve the effectiveness. Other vaccines stimulate both cell-mediated and neutralizing antibodies, and so on and so forth. I'm not going to go through this into detail. This slide is a whole lecture in itself. I just want to point out here that if you want to get involved in vaccination, there is a long list of things you need to know before you start to give a vaccine. And the most important part here is who should get it, who shouldn't get it, and what response can you predict from giving this vaccine? Next slide, please. Now, what's very important is how many doses you're supposed to give. So, for instance, measles, rubella, yellow fever vaccine, they give you around 95 to 80 to 95% effectiveness, meaning you develop antibodies and cell-mediated immunity after the first dose. In order to get the second 5 to 20%, you give a second dose, and then you get up to around 97 to 99%. So not everyone needs the second dose, but instead of testing everyone who got the first dose to see if they need a second dose, routinely we give a second dose to everyone. And these new vaccines coming out, by the way, the mRNA vaccines and the other ones, many of them, or there are 5 of them right now getting approved, and 3 of them at least needs 2 doses. Next slide, please. So in this little pamphlet that I talked about here, there are tables about contraindications and precautions. The most common one is severe allergic reactions. You can also get Guillain-Barré syndrome, Arthur's type of hypersensitivity, severe acute illness, and so on and so forth. Next slide, please. And there are also times when you think that you have got a severe reaction, but it's not a severe reaction, it's just a common perceived contraindication and precaution. So I'm putting this up here because I know there's a lot of people who really want to get involved in providing vaccination to their patients. And I would caution you, it's not just a matter of knowing how to inject something into someone's muscle or deltoid or wherever you want to inject the vaccine. There is a lot of other information you need to know in order for you to start to give this vaccination. Next slide, please. All right, what about the influenza vaccine? This came out on August 21st, and it's recommended in the United States today that you do take the seasonal influenza vaccine. And the reason for that is that you want to be able to reduce the signs and symptoms of regular influenza so we know that someone has COVID, because if you remember, the signs and symptoms are very similar between patients with COVID and influenza, obviously. So influenza vaccine, and I often get this question, influenza vaccine is recommended even today with COVID around, and it's highly recommended in order to not have a misdiagnosis. Next slide, please. All right, how many vaccines out there? It's estimated that there are 57 vaccines right now in clinical trials against COVID, and 87 preclinical vaccines. Preclinical means they are in the phase of animal studies or laboratory studies, but they have not been tried on humans yet. But 57 vaccines are already been tried on in humans. Next slide, please. These are the 5 that, as of a week ago, AstraZeneca, Janssen's, Moderna, Novavax, and Pfizer. And as you can see, there are 2 of them here, Moderna and Pfizer. They are this mRNA vaccine I talked about. The first 2 ones there are vector vaccines. As one is a chimpanzee adenovirus, the other one is an adenovirus 26. So they are actually using this adenovirus to take the DNA of the virus in order to get the immune system to react. And then you have the Novavax. It's a recombinant protein, meaning it's a protein that has the units or the genetic material embedded into nanoparticles that also is going to get the body to think that being infected with the actual virus. 2 of these vaccines may actually get approved in the United States within the next week. And they estimate that if that happens, we could actually have up to 10 to 15 million people being vaccinated before the 1st of January already. Today, actually, in the United States, it was voted on at CDC, the Center for Disease Control and Prevention, that the first recipient are going to be healthcare professionals and elderly individuals who live in elderly care facilities where they don't have access to the type of high-level medical care that otherwise would be available to them. So those will be the 2 groups of individuals going to get a vaccine first. Next slide, please. Next slide, please. Okay, just very quickly, this is from Pfizer. This is how the mRNA vaccine works. So you take the spike protein, you synthesize from the spike proteins the RNA. Next slide, please. From the RNA, you embed it into these lipid nanoparticles, and then you inject it into someone, and it goes into a cell. Next slide, please. And this cell is now going to start to replicate this spike protein that the body is going to recognize as the virus, and you're going to have T cells and B cells being produced, and you're going to have antibodies and cytotoxic cells. So that's how the mRNA vaccine works. Next slide, please. Next slide, please. Oh, sorry. No, go back. Sorry. Go back. The last part here. This is why it's so exciting with this mRNA vaccine. You can actually take an mRNA vaccine, and there's actually studies that are being published right now that show that with one mRNA vaccine, you can actually put the sequencing in that synthetic RNA for 20 different antigens from 20 different diseases. And if this works, and people believe it's going to work, you may actually one day be able to use this type of vaccine with 2 shots given to your kids, 2 shots, and you cover more than 50 different vaccinations. So that's the exciting part with this mRNA vaccine, that it might be available soon for other diseases. And this whole COVID thing has actually made the production and the studies about the mRNA vaccine has gone very, very quickly. And we are very excited about this type of vaccine, not only for COVID, but it could be an answer to, in a couple of years from now, your kids will get 1 or 2 doses of vaccine, that's it, for a lifetime, and be protected against 20 to 30 different diseases. Next slide, please. Okay, lastly, I'm just going to talk about 2 things very quickly. One thing we talk about here is vaccine efficiency. And vaccine efficiency is technically if you give the vaccine to people, you have a control group and those who get the vaccine, what percent of the people actually get the disease? So if I can take one of these vaccines, the Pfizer vaccine as an example, they had 170 people that got sick, 162 of those in the placebo group, and 8 in the non-placebo group. 8 of those who got the vaccine, 100 and 162 of those who didn't get a vaccine. So you divide 8 by 162, and that's the vaccine efficacy, and that's how they got the 95%. Now, what's the problem with this? Next slide, please. The problem with that is, keep going, next slide. Next. The problem with this is the following. If you look at the middle thing that I wrote here, there are several types of vaccine efficacy. One is to prevent infection, other to prevent disease, and the third is to prevent severe disease. Now, the way they determined the efficacy of this vaccine was how many actually got the disease. 162 got the vaccine who got placebo, 8 got the disease who got the actual vaccine. But how many people got infected? We know today that a lot of people can get infected with COVID without having disease. So that will not prevent those other people to infect other people. So today, the vaccines that are being tested, they are being tested based on the efficacy of preventing the disease. They're not being tested to see how effective they are to prevent infection. And we don't know that. We have no idea about these vaccines if they prevent infection. We know that they are effective to prevent disease and maybe even severe disease, but that's all we know. So that's my concern with these vaccines, is people are going to believe that this is the panacea. This is the answer to everything. And it's not the answer to everything, because we don't know if people get this vaccine, if they still can get infected. And if they still can get infected and they believe they are not infected, obviously they can continue to spread the disease. So we have to ask the right question. And the question I'm asking right now to these vaccine manufacturers is your vaccine there to prevent disease, or does it prevent infection? Based on that, I can then obviously figure out what to do. Jump a couple of more slides until the almost the last slide. Let's go through the next couple of slides very, very quickly here. Keep going very quickly. Let's go through the slides very quickly here. Keep going. Yeah, next slide. Oh, stop there. All right. So why are we talking about vaccine? There's something called herd immunity. Herd immunity is the following. Here you have on the left-hand side, you have the guys in blue. They're not infected, and the red people are infected, and they are sick. Now, obviously, if you put those in a population, you're going to have a lot of people in the population get very sick. Next slide, please. Now, you could have some people that are immune, either because they got infected previously or because they got vaccine. Next slide, please. So now, less people are going to get infected, but people are still going to get infected. Next slide, please. But if enough people are immune, we don't need everyone to be immune, but if we have enough people to get immune, that are immune, next slide, please, we will be able to protect the vast majority of the population. And this was called herd immunity. So what we are anticipating with COVID is that you need at least 70 to 75% of the people being immune, either through having been exposed or getting the vaccine. So if I now have vaccine that is 75% effective, and let's say only half of the people are willing to take it, well, I only get around 38 to 40% of people being immune. That's not enough. So we need everyone to take the vaccine in order to achieve this herd immunity here. Otherwise, this vaccine is not going to help us very much. Next slide, please. The last thing I want to just mention is we have spoken about these very new type of vaccine. But as I mentioned before, COVID infects through a receptor that we find in the mucosa. We have it in the mouth through the GI. There's also a mucosal type of immune system with IgAs. And there are mucosal vaccines. Polio, for instance, there was an oral polio vaccine. It was actually on a sugar cube that you took, and that's how you got vaccinated. I hope in the future we may actually see some of the mucosal vaccine being developed for COVID as well. But I haven't seen any of those mucosal vaccine being developed at the present time. But maybe in the future we'll see that. Next slide, please. Next slide, please. All right, so what do we need to know as dentists, as our healthcare professional? I think we should know about the different types of available vaccines. We should know who should get vaccinated. We should know about the diverse events. We should know about reporting requirements. And if you want to learn how to perform immunization, the storage is very important. Jaime, you mentioned something about that they need to be stored at a very, very cold storage facility. That is true if it's the nanoparticle that's involved, because it's a lipid type. But there are AstraZeneca, their vaccine, for example, you can keep for long periods of time in regular refrigerators. You don't need this very, very cold environment. So the AstraZeneca vaccine, although it's not as effective, it's only effective up to 60 to 74%, you can keep it for much longer period of time. So most probably that's the vaccine you're going to see in Africa and Asia and poor countries that don't have the facilities for this very, very minus 70 or minus 50 degrees that we need for the other vaccines. I think we also need to be able to educate patients about vaccine, and we need to advocate for immunization, meaning as dentists that see a lot of patients, we should try to advocate for and try to get patients to take this vaccination, because otherwise we're never going to achieve herd immunity. And if we don't have herd immunity, we haven't achieved very much. All right, I know this was very quick, and as you can see, there's a lot of information in here that I didn't have time to go through, obviously. But thank you for your attention, and if there are any questions, very happy to answer them.
Well, Michael, we're going to go very fast to a short video, and then we're going to come back for a few questions and answers.
I'll hang around for questions afterwards.
Okay.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. no contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada, Colgate PerioGuard, con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, Michael, first of all, I want to really thank you and congratulate you for this presentation. I know you had a very long meeting all day, and you still had time to share all this information, which is, I think you have changed many plans tonight of many people who thought that, as soon as the vaccine was going to be available, and assuming that they can be vaccinated very fast and very easy, it's not only about me. For this thing to really slow down as far as the pandemic goes, it means a lot of people getting vaccinated and getting immune. Now, I have a couple of questions. Well, first of all,
one more thing. We don't even know how long the immunity is going to last. It's going to last for 3 months, 6 months, a year. The natural immunity may only last for around 6 months. We don't know. Is the vaccine going to help us to make it last even further? Here's the interesting part. The vaccines, they use attenuated or weakened viruses. They give the strongest immune response to last for the longest. But obviously, the type of platform we're using for these vaccines don't use attenuated or weak viruses. They use mRNA, which means the immune response is not going to be as strong as it would be if we had infected someone with a virus as the vaccine itself. So no one knows. We haven't seen it long enough. I think only a year or two from now, we will be able to have those answers to those questions, but we're not going to have those answers now.
Now, I have a tree, when you play billiard pool of 3 bands, it's a question on 3 bands. First of all, it's HIV has been around for 35 years, 37 years, and no vaccine has been created. And I assume it's not that it's not important. It's because the virus mutates, and then you cannot catch up with the mutations. So after so many years, the focus went not into preventing, but into creating something that will attenuate the you are HIV positive, but you don't develop.
You're making it a chronic disease. It becomes a chronic disease.
Okay, so they stopped pursuing the vaccine for the HIV virus. Now the A1H1. They found the help of retrovirals so fast that there was no intention 10 years ago or 11 years ago to go through after a vaccine. But this is like the whole world is racing for the vaccine, not only for the money that it's going to be involved if this stays forever. It's like kind of many people see it as the end of humanity. So don't you think that it's going to be easier to find a cure and it's going to be more secure than finding a vaccine with all the trouble you've gone through today in showing us that it may not, it creates some reaction in one person and a different in another person. So why isn't
I think we have to do both.
rush?
I think we have to do both. If you are a smart investor, you invest in both lines of defense at the same time. I think that this COVID is going to be with us forever. It's going to be an endemic disease. Now it's pandemic, it's going to be endemic, meaning it's going to have low grade, and we're going to have it for rest of our lifetime. We're going to have it. Are we going to be able to treat sick people and have a higher survival rate? Yes, I think absolutely. But there are still going to be people who are going to die from this disease, and people are going to get very sick. Here's my problem, though. And it's something we don't talk about because we don't know enough about it. And that is, people who get infected, even if they are asymptomatic, we know that they have damaged heart, they have damaged lungs and other organs that don't manifest yet, but they can manifest years later. So if you are asymptomatic and got infected with COVID, you don't even know that you are infected, and you still may have all these damages to your internal organs. So that's number one. Number two, that people get infected are called the long haulers, meaning you get infected, you survive, and then for months and months and months and months, you can't get out of bed. So it's not only the dying part, it's the chronic illness part is such that it's so indolent that you cannot even discover all those problems yet. I don't think we can answer your questions, Jaime, until another year or two from now, minimum a year or two from now. And that's why we need to focus on doing both treatment and vaccines at the same time.
There's another question. I'm not sure I understand it. The question is, what is the protocol that has to be taken in account so a vaccine can go to distribution? I guess it means if it's approved or if it's not approved, no?
Yeah. So there is an absolute approval process. So in the United States, it's what we call the FDA, the Federal Drug Administration. They go through the approval process, and it's a very intensive process that takes a very, very long time. What they do now, they get what they call emergency use approval. So it's not a real approval; it's just that you're allowed to use it. It's an emergency use allowing to use it, and the approval process is much, much less. It doesn't mean 100% that it's. Would I have liked the vaccine to be tested longer than just 3 months? Yeah, of course. Would I like the vaccine to be tested for more than 30,000 people? Absolutely. Polio was tested in over 4 million people, okay, before it was approved. So the approval process.
But there was no social media. There was no social media when they tested polio in 1 million people.
No, but the point is that there is a very, very vigorous approval process. But because we are such in a hurry right now, we're not going through the same process today as we would have if it wasn't such an urgency.
And now I hope I put it correctly. The question says, what's the point in having herd immunity if only a few % of people are gonna get it anyway? The vaccine probably is as risky as getting the virus for younger people.
Well, the point of getting herd immunity is obviously that you can only get herd immunity if enough people are immune. Otherwise, you don't get herd immunity. You don't get herd immunity through natural immunization. We have tried that, and unfortunately, it's estimated, at least in the United States, in order to get herd immunity in the United States, 5 million people are going to die. So that's not a smart idea. So the only way to get herd immunity is through the vaccinations.
Okay. Now I want to say, yeah. No, go ahead.
Yeah, go ahead.
Well, this is my next question. You gave us a very, low flight over the history of vaccines. But what is your personal opinion? This is not. I don't think this doesn't have to do necessarily with statistics, but why is this anti-vaccine movement so strong? Is it really because people really think that through G5 they're going to control people who get a vaccine, and we're going to be like zombies that will obey the power of the deep state? Why is so strong?
Why
you have an opinion on that?
Yeah, why did 73 million Americans vote for Trump? I don't have answers to these things.
Yeah. No. But vaccines. These, parents who don't vaccinate their children
Yeah.
don't take into account what will be their life if they haven't been vaccinated by their parents 30, 40, 50 years ago. They just don't
No,
realize it.
I can tell you something else. Today in the United States, if you are a pediatric dentist, you can refuse to treat a non-vaccinated child because you don't want to have a non-vaccinated child in your waiting room. Because even
Yeah.
if you got the vaccine, you may not be immune. So having these non-vaccinated kids that have a high chance to be sick, you may actually get a vaccinated kid sick as well. So this is very, very complicated. It has to do with conspiracy theories, has to do with people believing that there's certain things in the vaccine that cause different other diseases, autism, and so on and so forth. And it's been proven that it is false. But people still believe it, unfortunately. And there are specific areas in the United States, like California and Colorado, some religious people, they don't vaccinate the kids. And I think it's horrendous. I think it's terrible because they put all of us at risk, unfortunately, every one of us.
Yeah. Let me have one more video, Michael, and I have two more questions, and then we're going to let you go.
Okay.
So please don't go. Don't go away. We'll be right back with two final questions.
Una boca más protegida con Povidone Oral Gargle, el único enjuague bucal antiséptico efectivo al coronavirus humano. Su composición química al 1% de iodopovidona elimina el 99.9% de bacterias, virus y hongos. Povidone Oral Gargle, cuida tu salud. Además, conoce la línea Radical, antiséptico y desinfectante orgánico de superoxidación. Protección para los que aman. De venta en Ideas Dentales.
Well, I have two questions for you. You said that the success of the vaccines is to create more mast cells from CD8 than from natural killer cells. This is what. So,
You want to create antibody production and cytotoxic T cells.
Yes. So this is something that cannot be done on its own. I mean, in the lab.
I mean, you produce antibodies and cytotoxic T cells when you get an infection, right? If you get a viral infection, that's how the immune system gets stimulated, and then it protects you. But it takes several days for this acquired immune system to start working. When you get vaccinated, you already have these cells in your body that recognize this virus because the body thinks it's been infected by the virus before. It has the memory of it, so it can actually attack it immediately. And that's how it protects you. Now the question again is, does it prevent infection or does it only prevent disease?
Okay.
And that's
I got it.
That's the question.
And now, can you connect all the information you're giving us today with the FAST test? The test that gives you, the production of immunoglobulins?
You can look at the viral titer, the antibody titer. You can look at something called agglutination, figure out how well these antibodies works. You can look at CD8 cells to a certain degree, but
No,
it's very, very,
maybe
but it's,
maybe
but it's, but
my
it,
question maybe was wrong, but if you put the vaccine and the vaccine is working, if you do a
yeah,
fast test, it will give you positive.
no. What do you mean with a fast test? I mean, if you do a blood
Yeah,
test,
the
can you
one you
see if
do
you
the
develop
drop
antibodies?
for the
Yeah,
IMG and
you
the.
could, you could see if you develop antibodies, but you also have to figure out if these are protective antibodies. You also have to figure out how long term the antibodies are going to be there. You have to figure out if you have the right type of CD8 cells and memory cells for this specific virus, etc., etc., etc. There is no test. There's no one test for that today. Doesn't exist.
Okay, because when people get sick, on the fifth day you can start having some of this, and then if you're already immune, whatever that means, you already
Right.
have the IG.
G.
What's IgG?
G.
Okay, so when people get vaccinated, some people go through the disease. People that
Oh,
get
no,
the
no, they
shot for
don't
the
go through the
flu,
disease. They don't go through the disease
but people who
necessarily.
get vaccinated for influenza, they some of them develop a very influenza
Jaime,
type of cold.
Jaime,
Yeah.
because influenza is an attenuated or a weakened virus.
Okay.
So some people will then react as they've got the disease. Now, if this had only been something else, they might feel nauseous, they may get a little sick and this and that, but not if they got something else. If they didn't get the attenuated weakened virus, they got, let's say, the spike protein, they may get a reaction and get the vaccination, but not against the protein itself.
Yeah.
Okay,
No,
so that's important. But wait, let me add one more thing. There's also something called passive immunity. And that is, let's say you have developed COVID. That means you have developed antibodies. So now I draw your blood, and then I take out of your blood the antibodies. I have them now. Can I give them to someone else to protect them? And that's the plasma, the convalescent plasma people are talking about, right? Now that could work, but it has no memory cells. So it only works while you have it. As soon as it disappears, you don't have the protection any longer, obviously. If it gives it protection. It turns out that this convalescent plasma did not even get FDA approval for emergency use because it wasn't effective enough.
okay. No, my question was that if people get vaccinated next year, if there was a test that they can do and say, okay, it's working, I can ease up the distance and other things. So there's no way to know if the vaccine was successful in your case.
Well, it's a very hard answer because you want a yes or no answer to a question that doesn't have a yes or no answer. You may have developed antibodies. You don't know how effective those antibodies are. You may have developed these cytotoxic memory cells, but you don't know how effective those are. So you can measure the titer of those cells, but you cannot measure how effective they are. So that's number one. Number two, we have seen that COVID mutates. So you may have antibodies that may not be as protective any longer because you have antibody against the wrong protein. So it's a very, very difficult question to give you a yes. I know you want a yes or no answer. I cannot give it to you.
No. I just think that I'll better invest in face masks because they're going to be here for a long time. A
Yes,
very
they
long
are.
time.
Yes, they are.
Very
No
long time.
question about it.
Okay. Do you want to make any last comments? I want to let you go because you really had a. Um,
Had a long day.
yeah. So you want to say something else before we let you go?
No, I thank you for the opportunity. I think this vaccine thing is very interesting. I think we need to know more about it. I think we are at the beginning of becoming more knowledgeable about vaccines. This new mRNA vaccine is very exciting, but we don't have enough information about it yet to be able to say it's going to be effective and how effective it's going to be. We don't have the test that you're looking for in order to see how effective the vaccine was. But I think there's certain question we need to ask. When they talk about vaccine efficacy, are they talking about preventing disease? or they talk about preventing infection. And I never hear that. I never hear those questions on the news. It's almost like they don't want to ask the question or don't know that they should ask this question because it's going to make a huge difference what type of vaccine there is, obviously. Number two, the antibodies and the cytotoxic T cells that are being developed, how long are they going to last? I don't have an answer to that one either. So those are
Well,
important questions I ask myself today that I don't have an answer to, and hopefully we will, but we're going to have to wait a long time. So in the meantime, yes, I'm going to wear my mask. But wait.
well,
But
I remember.
there's
Yeah.
one more thing. And this to me is what I'm most scared about. That people are going to trust because people have been told vaccine, everything's going to be fine. For as long as we have the vaccine, we're going to be fine. No, you're not going to be fine. That's the problem. And people are going to say, okay, the vaccine is here, and now I can go out and drink, I can take my mask off, I can socialize. No. Not yet. We don't know enough about it yet. Don't believe that the vaccine is the panacea. They're going to solve the COVID problem for us. It might, if we are lucky, but we have to be very, very lucky for that to be the case.
I'm going to tell you something. You changed my life plans completely tonight. No, I'm serious. Absolutely. I said, well, it's going to be a couple of months, maybe another 2021 complete. But what you've told us tonight, it's before there is a real cure. And as you say, what's the cure if there is damage to some organs that may, don't say what's done to people's
Heart.
mental health, not only dental health but mental health.
Oh, yeah. Right.
Yeah. Well, I hope you join us in 2 weeks' time so we can have a last program of the year. It's we're gonna have 2 more programs, one on December the 8th and one on December the 15th. And I hope you'll be back in 2 weeks. And we can take a look at the whole year and maybe get some guests. Our first talks in March, in April. Oh, the vaccine will be, and now, woo, who expected so many dead people? It's what's happening in Mexico is unbelievable. And they still say that it's not important to wear a mask. We were not as lucky as you on Tuesday, November the 3rd. So anyway, Mike, go to sleep. You need a good night rest.
All right. Thank you very much. And everyone, good night and stay safe. Wear a mask.
Okay.
Take care. Bye-bye.
Okay. We'll go to a short video. Bye, Michael. This is a video just to remind you that if you go to ID Academia and you press on the videos, the video section of the ID Academia channel, you can see all the programs from the very beginning. We started on Zoom. We used to have, we didn't have such a nice production at the beginning. And then we were able to do that thanks to all our sponsors. And please don't let anybody fool you. You don't have to buy these lectures. They're completely free. They were done by people with goodwill. It must be very interesting to go back and see the lectures of 8 months back, or 6, or even 4, 2. And again, you can watch them online. I also want to thank Samantha that I think there was a small problem at the end with the internet. This is the problem when we go live. Thank you, Samantha. Dr. Samantha Rispe is our translator every other Tuesday. So a special thanks for her. She lives in Monterrey. And we're going to go to a very, very short video, and we'll be right back with very important information for you. Don't go away.
OrthoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrthoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%, libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrthoGuard, con 5000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel, indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, we had other questions, but unfortunately we had to let go Dr. Glick because he had a very, very intense day today with a group of researchers from the University of Connecticut, which is my home school. That's where I did my postgrad residency many years ago. Please, I just want to remind you that if you go into the dental sphere, the Congress that we had on November 19th and 20th, it's still, the place is still open 3 more days until Thursday. So if you couldn't see one of the lectures, you just go in with the same user and password you got when you registered to the platform, and you can still see all the lectures from Thursday the 19th or from Friday the 20th, and you can still go into the very small exercise exhibit that we did. We thank also all the sponsors who wanted to support this idea. And from what I'm getting, I think it's going to be a very long time before we can go back to normalcy. Probably we'll go through a time with the hybrid lectures where some people will go and some will be remote by video. Who knows? It seems like we would know a lot more now at the end of 2020 of this very, very hard year. And it's my impression that we still don't know many, many things that are yet to happen. I wish you all well. I wanna, unfortunately, we lost a very good friend. He was the dean of the dental school in Torreón, Dr. Oscar Rodriguez. To all his friends, his family, we send our love and our prayers. He was a very good friend, an excellent dentist, an excellent teacher, and always eager to help everybody who asked him. And you know, unfortunately there are a lot of friends that we are losing. And for all of you who are still watching tonight, please stay safe. And we'll be back next week with a very interesting program in Spanish. Remember, our programs in Spanish are at 9 o'clock. Our English versions are at 8 o'clock Mexico City time. So once again, thank you to Colgate Palmolive Mexico, to Ideas Dentales, and to Fast and Sharp for supporting the production of this program. And I just want to say good night, and please come back next week. We're going to have a very, very interesting program. It's going to be the last Spanish program of this 2020. Good night. Stay safe.
Si te lavas bien las manos, lograrás prevenir